Muy buenos días. Vamos a iniciar esta actividad. Acabamos de finalizar la parte en terreno del operativo. Estamos muy contentos. Todo resultó muy bien. Se pudieron hacer todo lo programado. No hubo problemas logísticos ni de ningún otro tipo. Así que ahora viene toda la parte que ustedes saben de análisis de datos y toda la información que podemos obtener y los resultados para los pacientes. En esta última semana nos acompañó el doctor Moriyama, quien viene desde la Universidad de Kyushu en Japón, y él estuvo toda la semana con nosotros, dándonos su retroalimentación de las endoscopías que hacíamos. Y esta vez vamos a aprovechar su presencia acá para que nos haga una presentación que es la evaluación, la detección del cáncer gástrico temprano y la utilidad de la telemedicina para eso. Así que dejo con ustedes al doctor Moriyama. Doctor Moriyama, por favor.
Hola, this is Tomohiko Moriyama from Kyushu University Hospital of Fukuoka, Japan. It is a great honor for me to make a presentation here today. I really appreciate Dr. Pablo Cortes for inviting me. Okay, I'll start my presentation. I talk about how to detect early gastric cancers more by endoscopy. As you know, in Chile and Japan, age-adjusted mortality rate of gastric cancer is very high. This is a map where here is Japan, here is Chile. Very red, the colored red is a very high incidence area of gastric cancer. But in Japan, mortality rate of gastric cancer is decreasing year by year. Why? I think there's two factors. One is development of endoscopic technology and technique. And another one is decreasing incidence of H. pylori infection in Japan. But as you know, the gastric cancer is a disease for older age patients. In older generations, H. pylori infection rate is still high in Japan, so that's why I think the former factor is really affect to decreasing in number of gastric cancer deaths. High definition image zoom endoscope with NBI, transnasal endoscopy, EMR, and ESD. These new technology contribute to the decreasing of gastric cancer deaths, I think. This is clinical practice of gastric cancer. We have to detect the gastric cancer by white light imaging first. After that, we characterize, and if possible, we can treat these diseases by endoscopic procedure or surgical operation. But in these sequences, advanced technology and techniques contribute to the characterization and treatment of gastric cancer. We have to think that the detection by white light imaging is a first step to start to treat gastric cancer. So, for detecting many early gastric cancers, we have to get a good view field and watch the full gastric mucosa. And furthermore, we have to know endoscopic findings of high risk for gastric cancer. To be aware of abnormality by white light imaging, we have to get a good view field. Getting good view field is essential. Then, what is good view field? The answer is no mucus and foams on lens and mucosa. We have to clean the lens frequently and wash the mucosa sufficiently. In this view, we can detect much mucus and foams on gastric mucosa. This figure shows mucus and foams located just above the gastric mucosa. In this situation, irrigation dye, the dye easy to degenerate and inhibit our view field. We can get clear images by this situation, in this situation. And if we try to zoom with NBI, but we can't get unclear images in this situation. So, we have to remove the foams and mucus using anti-foaming agents, mucolytic agents, and water. After that, we can get clear image by white light and if we spray dye, we can get a clear images of chroma endoscopy. And we zoom in this area with NBI, we can get clear image like this. We have to get high quality images, we have to lava mass. This is a movie. There are many forms and mucosa, forms and mucus on gastric mucosa. So we wash the mucosa using the built-in jet function. Wash and wash. All we have to do is wash in the mucosa before starting the observation. After that, we can get a clear images like this. Then there's also a scar over there. Next, we have to watch the whole gastric mucosa. We have to suction the fluid as possible and inflate the lumen and reduce the blind spots as possible. Inflating the lumen is very important. Left figure shows the inflative state. We can see the blue colored paper in this photo, but in deflated states like this, it is very difficult to find the blue colored paper. We can't detect like this. We can't detect the large, even in large lesion in the especially in the greater curvature, because there are many gastric folds in greater curvature of the corpse. And next, we have to reduce blind spots in the stomach. We have to take many photos at predetermined site. Dr. Yao developed systematic screening protocol for the stomach, SSS, in 2013. He recommended to take more than 22 pictures of the stomach. In antegrade view, we have to take a photo in the antrum to lesser curvature, anterior wall, greater curvature, and posterior wall. In the lower body, we have to take 4 photos: lesser curvature, anterior wall, 1, 2, 3, 4. And mid upper body, we have to take 4 photos: 1, 2, 3, 4. Same in the fundus and cardia. In retroflex view, we have to take 4 photos: lesser curvature, anterior wall, greater curvature, and posterior wall. And in the middle upper body, takes 3 photos: lesser curvature and anterior wall, posterior wall. Same as the gastric angle, we have to take 3 photos. That's all. Of course, you can take more pictures if there is a lesion suspicious for gastric cancer. And next, we have to know endoscopic findings of high risk for gastric cancer. As you know, most of patients with gastric cancer are positive for H. pylori. H. pylori infection induces chronic gastritis, and gastric cancer arises from atrophic gastric mucosa. So we have to know much more about representative findings of H. pylori infected gastric mucosa. This is famous findings of RAC. In left picture shows positive for RAC. This is this patient are negative for H. pylori. In right picture, this is the disappearance of RAC. We can't detect the spider-like small vascular in this area. This is the gastric angle. We have to detect the presence of RAC in gastric angle or lower part of the corpse, in lesser curvature of the lower part of the corpse. And these are other representative findings for H. pylori infected gastric mucosa. Left picture shows mucosa atrophy. We can detect any gastric fold in the greater curvature of the corpse in this photo. And right picture shows intestinal metaplasia. We can see these mucosa as whitish mucosa by white light imaging. Left picture shows hyperplastic polyp. And right picture shows xanthoma in the lesser curvature of the corpse. These findings are representative findings for H. pylori infected gastric mucosa. And we sometimes see the sticky mucus and the nodularity in the antrum. Of course, we can see these findings in the corpse. These are also endoscopic findings for H. pylori infected gastric mucosa. If we see these findings, we have to take much care to find early gastric cancer. And to this patient, we have to know we have to aware the sign of a suspicious lesion for gastric cancer. We have to take care of the surface changes, and color changes, and abrupt changes in vascular and mucosal pattern. Dr. Yao also developed a GUP system. This is quite easy. GUP is corresponding to the Paris classification. The G means gastritis-like lesion. Gastritis or superficial cancer like the 2A, 2B, 2C. U means ulcerative lesions, peptic ulcer or superficial cancer with ulceration like 03, type 03. P means polypoid lesions, polyps or polypoid cancer. We can detect polypoid cancer very easily. We can also detect an ulcerative lesion like this, but sometimes it is very difficult to differential diagnosis. G, gastritis-like lesion, 02C, is very difficult to detect, and differential diagnosis is also difficult. In this photo, we can detect a reddish area here. This is a gastric cancer, early gastric cancer. We resected the lesion by ESD. Like this slide, we have to aware the gastritis-like lesion, ulcerative-like lesion, polypoid-like lesion. And we also aware multiple synchronous lesions in patients with H. pylori infection. This is endoscopic diagnostic algorithm for gastric cancer in our institute. We first intubate scope, and after that we wash the mucosa first. We wash and wash. After that we start to observe. But just before starting observation, we judge the H. pylori status at the lesser curvature of gastric angle or lower part of the corpse. Using we judge the presence of RAC or other representative findings of gastric H. pylori infected gastric mucosa. After that, we observe carefully in the stomach. If there's no lesion and we judge to be negative for H. pylori, we immediately extubate scope. And if we judge to be positive for H. pylori infection, in Japan, we spray indiocarmine. Of course, this is an strategy of our institute. We spray indiocarmine. After that, we observe the whole gastric mucosa by chroma endoscopy. And if there is a lesion suspicious for gastric cancer, we do a zoom endoscope with NBI. But if we don't have the non-zoom endoscope, we have to take a biopsy specimen from this lesion. Of course, after zoom observation by NBI, we will take a biopsy. After that, we extubate scope. So, good view field is essential for detecting early gastric cancers, and we have to lab a mass for getting good view field. SSS, systematic screening protocol for the stomach, can reduce blind spots in the stomach, and careful observation is needed in patients who have representative endoscopic findings for H. pylori infection, I think. Then one more thing that I want to say. This is a proposal of multi-center study. Kyushu University connected many Latin countries via nets. And from a few years ago, we started regular teleconferences on the net. This is one of the pictures. This is Japan, Chile, Mexico, Brazil, and Costa Rica. I think Latin American endoscopy teleconference is a very good opportunity to create standardized esophagogastroduodenoscopy procedure which is commonly applicable in clinical practice in Latin America in order to improve early gastric cancer detection rate. So, if we apply a standardized protocol to clinical practice and if we increase experiences by sharing detected cases via teleconferences, EGCDR may increase. So, we have to make a now we consider the new design the clinical trial. This is the PICO of the study. Patients as endoscopists in Latin America. Intervention is introduction of standardized EGD protocol and teleconferences, mainly case discussion. Comparison is early gastric cancer detection rate before intervention. This is a single-arm study. Outcome is EGCDR after intervention. This is a scheme, but tentative. Before starting 3 times Latin teleconferences, we have to make EGD database for 3 months. And after 3 teleconferences, we also make an EGD database for 3 months and compare the EGCDR between 2 periods. Point of the study in Latin countries. This study is done for improvement of EGCDR in clinical practice. This is a prospective international multi-center study. In this study, intervention is 2 doctors, not 2 patients. And we can do an interactive discussion on these teleconferences. Thank you for kind attention. We hope you will attend this project. If you have some you interested in our this study, please call me and mail to me to this address. Thank you for attention.
Muchas gracias, doctor Muriyama. Entonces tenemos tiempo para preguntas. Si es que quieren, a través del chat, del WhatsApp, pueden hacer preguntas. Dr. Muriyama, you have been with us for 1 week.
Yes.
You can show our endoscopic techniques and our technology, our equipment, and what do you feel? What do you think about the level of endoscopy for the diagnostic of early cancer gastric, and what do you think is the more important part to improve that?
Okay, thank you for the question. Technically, I think it's enough. You have a good level, you have a good skill for detecting early gastric cancer, but the washing the gastric mucosa is not enough, I think. Most of the people are H. pylori infection in this country, same as our country, and there are much mucus and forms in these patients compared to the non-infected patients. So we have to wash more lava mass. I think so. And we have to have more experiences. We have to take care of the characteristics findings of early gastric cancer. So, but I think that we can have more experiences using these teleconferences. That's why I want to join all the people all endoscopists in Chile to get more experiences about early gastric cancer. Technically, it's enough, I think.
Thank you. And another question. We don't use the indigo carmine dye in all the endoscopy. Every time we have more equipment with electronic magnification and chromoscopy. Are similar or are different? What do you prefer? Dyeing with chromoscopy, dyeing with electronic chromoscopy?
Yeah. I think the chroma endoscopy is very, very easy to and we can detect the early gastric cancer very easily. Of course, we have to wash before irrigating dye. But I know it is very difficult to get the indigo carmine in this country. Of course, in other countries, including Asian countries, it is very difficult to get indigo carmine. It is a little bit expensive compared to Japan. In Japan we can get indigo carmine very cheap and very easy. So, but the zoom endoscopy with NBI, we have to have more experiences. It is a little bit difficult compared to chroma endoscopy to detect early gastric cancer. Zoom endoscopy is quite useful for characterize a lesion, but it is not so useful for detection. In detection, the chroma endoscopy is quite useful. So that's why I prefer to use the chroma endoscopy, but in Japan. So in other countries, we have to find early gastric cancer by white light imaging. So perhaps to characterize the lesion, especially in the to evaluate the extent of the lesion, to find the demarcation lines of the lesion, almost nearly equal by chroma endoscopy and by zoom endoscopy. So it's okay. If we have an experience, then we have good eyes to detect early gastric cancer by white light. Right.
Yeah, I have other question.
Hmm?
You usually use pronase
Pronase, yeah.
for clean the stomach. This week you saw that we use a combination of N-acetylcysteine and simeticone. What do you think about this combination with your experience with pronase? Are similar or is best pronase?
It is a little bit difficult because we didn't compare directly. So, but for my opinion, it is not so bad using the simeticone and N-acetylcysteine for as a pre-operative preparation. It's okay, and I believe that these agents makes the view field clear, more clear. So I prefer to use, I recommend you to use N-acetylcysteine and simeticone. I believe that these agents makes it better.
And for the systematic evaluation, is really necessary to take the photos, or is enough to view like if I take the photos, but without take the photos? Is necessary to take the photos or not?
Yeah, I think so. I believe that the taking many photos is necessary because there are many blind spots in the stomach, especially in the posterior wall and lesser curvature, around lesser curvature. So it is a lesser curvature of cardia. There's many blind spots in the stomach. So by taking many photos, we can aware there are many blind spots in the stomach. If we can't take photos, we don't aware this point. So to take photos at the predetermined site, we try to see these blind spots. We making a great effort to take a photo to these blind spots. So it is very important thing, I think. So we have to take many photos at predetermined site using SSS. Right, I think so.
More question. How is your relation with the pathologist? It's close. You make meeting. How long?
Yeah, it is very important because when we find the lesion suspicious for gastric cancer, we'll take a biopsy specimen. But the answer is from pathologist. We can't find answers without pathologist. Pathologist comment is very important for us. So we have to closely communicate with pathologist. In Japan, we can call the pathologist and anytime we want. I know the pathologist phone number and I can access to her anytime I want. And I make a question. I ask her to what's this and what do you think about it? And is this a cancer or non-cancer? This close communication is very important, I think. And from, of course, we can learn from pathologists, and also pathologists can learn from us, endoscopists. So through this communication, we can educate each other, and the detection. It makes perhaps it makes the increase the detection rate of gastric cancer, I believe.
When with your fellows,
Mm-hmm.
how is the training for your fellow for to this problem for to improve the detection?
Right. Okay. We in our institute we have many endoscopists, as you know. So in daily practice, and if there's some lesion suspicious for gastric cancer, they call us, and we go there and watch the lesion with them and assess. And we teach them to its technique and it's our knowledge. And after taking a biopsy, we recommend them to take a biopsy. Of course, if we think it's not non-neoplastic lesion, because it's perhaps it will contribute to their experience. So, we recommend them to take many photos, and after a while we reviewed all the photos by all the endoscopists in our institutes and assess its quality and is there any blind spots. And we educate them again and again, and they learned a lot from us. When I was a fellow, I was taught by my trainer. Right.
How you select the patient who you perform ESD or surgery? How you evaluate the depth of the lesion, the invasion? You use ultrasonography or not?
Yeah, sometimes I use ultrasonography, US. Now, of course, we can reject the gastric cancer if this lesion is restricted to the mucosa. But and now we can reject large tumor, even large tumor, by ESD if the lesion localized in the mucosa area. So we choose surgical operation when the gastric cancer, depth of the gastric cancer is submucosa in area gastric cancer. We recommend the people who have gastric cancer to reject the ESD, mainly ESD.
And one last question. How you select the population to perform endoscopy? You select of any form or all it's only for age? How you decide which patient need an endoscopy or not?
All patient, especially in the H. pylori positive or H. pylori patient. In patient with negative for H. pylori, gastric lesion is very rare, including peptic ulcer, of course, in gastric cancer, and lymphoma, multiple lymphoma, something like that. But now sometimes we see gastric cancer arising from non-atrophic mucosa without H. pylori infection. So I don't think there's no need to perform EGD to these patients, but there's no guideline. But we recommend the patient with negative for H. pylori once in 4 or 5 years, I think. But in patients with H. pylori infection, we recommend them to undergo EGD every year.
Every year?
everywhere, even in eradicated patients.
Okay, thank you very much. You have a final words? Something?
No?
No? Okay, thank you very much, Dr. Moriyama.
Thank you so much.
Muy agradecido por su presencia acá y por haber estado toda esta semana con nosotros. Muchas gracias a todos y nos vemos en otra oportunidad.